welcome back everyone to the Global Heart Hub second annual Unite Summit. The next session is perspectives on cardiovascular disease prevention, and we'll be covering both primary and secondary prevention in this section. As we all know, heart disease is a massive global problem, and we need to consider how we can stem this exponential rise in heart disease. Now, one way, of course, is preventing it in the first place, primary prevention. And the second is, if you already have heart disease, how can you prevent it from worsening or from putting yourself at risk of other conditions? That's what we'll be tackling in this important session now. I have got some housekeeping just to say. Please do use the Q&A format, not the chat, if you want to ask a question. We really do ask if you have questions. We've got two amazing speakers here for this section. Please do take the chance to ask them questions. And if you see a question that's been asked on that and you think it's a really good one, just press the thumbs up to bump it up. And yeah, please do use the hashtag just one thing. If there's one thing that you learn, the main thing, just please do fill it in on the platform on that section, and just let everyone else know what you've learned and why it's important. And then you can share that on social media, and also generally share with the hashtag GHHUnite to let people know about the Unite Summit. So thanks very much for that. I want to get on and introduce our first speaker. We have Professor Reena Gupta. She's professor at the University of California, and she's also Chief Medical Officer for Performance Improvement and Technology at a charity called Resolve to Save Lives. This is a fascinating and really, it's got an amazing goal. It's the ambitious goal of preventing 100 million deaths in low middle income countries. Professor Gupta is a practicing internal medicine doctor, and so she still sees patients as well as teaching, so a wealth of experience. Thank you so much, Professor Gupta, for coming here today, or being here today. Yeah, you've got 15 minutes for your presentation. Thank you.
Thank you so much, Jackie. It's really a pleasure to be here with you all today to talk about primary prevention of cardiovascular disease. As Jackie mentioned, Resolve to Save Lives is a global nonprofit organization working primarily in low and middle income countries dedicated to saving 100 million lives from cardiovascular disease and prevention of epidemics. We partner with country ministries of health, communities, organizations, and work in partnership with the World Health Organization, the CDC Foundation, and other partners in this work. And our riddle is, when does 50 plus 30 plus 0 equal 100? If we can increase global hypertension control to 50% from its current abysmal rate of less than 14% in most countries, if we can reduce dietary sodium intake by 30% and eliminate artificial trans fat in our diets, the world can save 100 million lives over the next 30 years. And these are three focus areas of interventions for cardiovascular disease prevention. Today, we'll talk mostly about hypertension, because as you all know, hypertension is the single largest modifiable risk factor for preventing cardiovascular disease and cardiovascular death, accounting for 10 million deaths annually globally, more than all infectious diseases combined. And treatment of hypertension can save more lives than any other clinical intervention for adults. This is the global hypertension treatment cascade of the 1.4 billion estimated people living with hypertension globally. Only 50% are aware of the diagnosis, and many fewer, only about less than 14% of those with hypertension globally have their blood pressure under control, 1 in 7 patients. To achieve UN and WHO targets will require more aggressive goals to reach 50% hypertension control. There are many obstacles that we face in effective treatment of hypertension that we distill into 3 categories, mirroring the cascade of hypertension care. Those pertain to diagnosis, of ensuring people are aware that they have hypertension, of treatment and linkage to care for those who are diagnosed, and of ensuring continuity of care and retaining people in treatment who have started treatment. And I won't review each of the specific components within each of the hurdles. I think the main, most important point of the slide is that of all of the many barriers faced to effective hypertension treatment, the only one listed here at the end of low adherence focused specifically on individual patient behavior. All of the other factors are really dependent on a responsive and robust healthcare system, and take responsibility for designing a healthcare system that is responsive and patient-centered to support and make it easy for patients to access and stay in care and treatment. So we have ambitious global targets of achieving 80-80-80 for hypertension control, which means 80% of those with hypertension are aware of their diagnosis, 80% of those aware are linked to treatment, and 80% of those treated have controlled blood pressure, which would translate to a 50% hypertension control of a full population level, far above the current rate, less than 14%. Our team conducted a modeling analysis recently looking at if we're able to achieve these 80-80 targets, the world could prevent up to 130 million deaths by the year 2050. So how do we achieve progress towards these global goals? 4 components that we emphasize are implementation and scale of the WHO heart standardized approach to hypertension treatment in primary care settings in low and middle income countries, improving medication access to preferred antihypertensive medications, decentralizing care so patients can access care in the community, often by non-physician health workers, and reinforcement of simple digital information systems to really be able to track populations and drive continuous quality improvement. So to spend a few minutes to talk about each of these, a standardized heart approach involves 5 components that are outlined here that make up the WHO heart technical package for effective hypertension treatment. The first is a simple, practical treatment protocol. A protocol is different from a lengthy guideline that sits on the shelf, really a one-page document that outlines simplified dose and regimen-specific treatment for hypertension. The second component is a stable supply of medications and blood pressure devices in all facilities. Third is team-based care involving non-physician team members in the care delivery team. And fourth, patient-centered services, really making care easier for the patients, as mentioned earlier, which often involves delivering care closer to the home in a way that's easily accessible and reducing financial barriers to treatment. And finally, a robust information system to support quality improvement. The WHO released their updated guidelines for the pharmacologic treatment of hypertension last year, which really focuses on 3 classes of proven antihypertensive medications that form the basis of many national hypertension treatment protocols. This is an example from Bangladesh. We've now worked in more than a couple dozen countries and found that developing a national treatment protocol is a key first step for building national hypertension treatment programs. And these one-page protocols can be pasted on the wall in primary healthcare clinics. The goal is to be as simple as possible. As you can see here, there's only 3 medications and 3 steps at the primary care level, which really can facilitate drug supply rather than countries at a national level trying to procure a spectrum of medications. Focusing on 3 core medications can simplify drug price reductions as well as supply chain management, and facilitates training of healthcare workers and team-based care with non-physicians to standardize treatment in a protocolized way. There's strong evidence that hypertension care delivered by nurses, community healthcare workers, and pharmacists is not only more cost-effective, but also preferred by patients and better quality, and often allows patients to be treated closer to home where they live and where physicians may not be available. Over the past 5 years, we've worked in 21 low and middle income countries on implementation of the heart technical package, training over 350,000 healthcare workers with over 7 million patients with hypertension enrolled in treatment, and over 2.8 million of those patients with controlled blood pressure documented. That translates to a blood pressure control rate of about 40%, significantly higher than the close to 14% where many of these countries started at the initiation of their programs. And I will mention that we really see hypertension as a pathfinder to strengthening primary healthcare more broadly. If this package can be implemented for hypertension, it's really the same 5 components that are applied for diabetes, for statin care, and cardiovascular disease, and primary care more broadly. So to speak on medication access, which remains one of the primary obstacles to effective hypertension treatment, with Resolve to Save Lives and partnerships with Doctors Without Borders, we released this year the Under Pressure Report, which examined antihypertensive drug availability and pricing in 5 low and middle income countries, and found that while many national essential medication lists align closely with the World Health Organization essential medication list for antihypertensive, the prices of antihypertensives vary substantially across low and middle income countries, with many countries having costs for antihypertensives that are 20 to 40% the cost-based generic price, leading to unaffordable drug prices for many governments and patients, and really an opportunity for numerous advocacy avenues and work on price reduction and efforts to increase affordability for patients, advocacy to ensure that these medications are covered in national health insurance packages, and other efforts to reduce costs for patients, especially in low and middle income countries. With respect to quality improvement, we've found that having simple often digital health information systems are key to tracking populations and effective hypertension care, to know who are the patients with hypertension, what are their outcomes, are they following up in care, what is the control rate. And at Resolve, we've developed a simple application. It's an open source, fast and free software for use by healthcare workers on their personal mobile devices to record patient care at the point of care. That's now in use in 4 countries: India, Bangladesh, Ethiopia, and Sri Lanka. We just this week crossed 3 million patients enrolled in care, and over 10,000 primary care facilities updated since the slide was developed. And whether it's simple or other simple-like digital information systems, in partnership with WHO and the University of Oslo, a DHIS2 package for hypertension was released at World Heart Day in September that follows these same principles of allowing healthcare workers to document patient care at the point of care, to provide dashboards to understand how the key indicators of how populations are doing, and to really support retention in care, which is often one of the main barriers to effective treatment, of being able to send automated SMS messages to patients, generate overdue call lists, and community health worker lists for following up with patients in the community, as well as a patient-facing app to track and monitor blood pressure control. So in summary, there's a clear package of services that countries can implement to prevent cardiovascular disease by effective treatment of hypertension. Unaffordable medications and weak information systems continue to be major obstacles and opportunities for advocacy and improving the quality of hypertension treatment programs. And several low and middle income countries are demonstrating an implementation of the WHO Heart Technical Package through national hypertension treatment programs are feasible in low and middle income countries, and really have the potential to prevent many cardiovascular deaths. So with that, I will turn it back over to Jackie. Thank you very much.
Thanks very much indeed, Professor Gupta. That's lots and lots to take in there. I think we're going to be having a few questions with Professor Gupta first of all. Professor Gupta, you mentioned all, there's some amazing work that's being done with this hearts program. You mentioned some barriers like unaffordable medications and weak medical information systems. But what about complacency? Is complacency something that is a problem, and with primary prevention?
I think so often there's a very strong emphasis on individual decision-making to make healthy lifestyles for prevention of cardiovascular disease. We often place the responsibility on individuals, but from a public health perspective, a larger issue is how can we design environments and enabling policies that really make choosing the healthy options the default for people. I think from a sodium reduction perspective, more than 90% of the world's population consume more than the WHO recommended daily limit of salt each day. And clearly, on an individual basis, reducing salt consumption is extremely difficult based on the food supply. But there's strong evidence that policies that limit salt in processed food and the supply of food can have a powerful impact. And so I think shifting the lens from placing the complacency that arises from focusing on individual responsibility to the public health approach can have a significant impact.
And how do you think that can be done, Professor Gupta? How will that shift be implemented?
Yeah, I mean, I think that as I was speaking to with respect to sodium as an example, many countries have taken action on policies that are leading to the UK being a great example of this, of significant sodium reduction that's translating to reduce salt consumption for prevention. As of this year, I think over 50 countries have now also put into effect policies to eliminate artificial trans fat. And so through momentum gained, the impact of really affecting nutrition at a policy level is one strategy.
But of course, you mentioned that as the salt initiative, and thank you very much for saying well done to the UK, where I'm based. But how can that be translated into the countries that you're talking about, the low and middle income countries where you're working with Resolve?
We're seeing significant progress in many of those areas as well. With respect to salt, I think a lot of it depends on, for different countries, the percentage of salt consumed and the sources of salt varies, whether it's home-based addition of salt to home-cooked food versus out of home salt that's consumed in external environments through processed foods or restaurants. So, for example, in China and other countries we're working in East Asia, Vietnam, where the majority of salt consumed is actually in the home, there's important innovations in terms of low sodium salts, increasing use of potassium salt for other things that are being implemented, along with policies for reduction of out-of-home consumption.
So you're saying there is political will in those countries where you're working to make changes, but presumably funding is an issue?
Absolutely. I mean, I think that the prevention of cardiovascular disease, in many ways, we know what the effective strategies are to implement to prevent cardiovascular deaths. It's the political will and the sustained attention and funding that are going to be necessary to make that happen. There's, I know the last session was on financing in cardiovascular health, and clearly traditionally less than a penny on every dollar in global health donor funding traditionally has gone to cardiovascular disease, despite it being the largest killer, and a lot of room for advocacy around how to build that political will and financial support. But I think the areas of success where that political will is there, of highlighting those stories of successes, like the examples of successful implementation of the HEARTS package that I was speaking of, and showcasing that in advocacy efforts to show that progress is possible in low and middle income countries in these settings, can be a powerful advocacy tool.
Okay, thank you. We've got a good question here. And a comment too. Great work being done within the Global South. how can we duplicate this work with marginalised and disadvantaged groups within the global north? For example, BAME communities in the UK and the EU. And that's a really good point, isn't it? So we think about the global north as, hey, you know, actually everything's okay, we're making strides and everything's checked. But actually, as we've seen, I think maybe Professor Wood will talk about this, but we've seen that lots of marginalisation amongst certain groups in the UK and Northern Europe.
Absolutely. Such a important point. And I'll mention, we often talk about the same components of the Heart's technical package are not unique to low and middle income countries and apply are just as relevant in most income countries. I'll speak to the US, where I practice and still practice as a primary care provider. That hypertension control remains much less than 50%. And, much of the model and the element of the Heart's technical package comes from the successful model of Kaiser Permanente in the US that's been able to achieve over the last 2 decades hypertension control of upwards of 90% in their population, utilizing many of those same methods of a simplified treatment protocol, team-based care models, supportive quality improvement using key indicators and digital information systems. And, in work, for example, that I've done locally in San Francisco, where we have a significant equity gap in terms of hypertension, have in the past equity gap in terms of hypertension control rates between Black African Americans and the general population, focusing on equity in those quality improvement efforts and closing of that gap through both team-based care efforts, engagement of patients and patient advisory boards, I think is just as relevant. The same principles often that apply in low and middle income countries apply in contexts as well.
And obviously this is a summit for patient organisations around the world. How do you think they can help governments think differently about the importance of important topics like early diagnosis, on genetic detection of people with no symptoms, for example? How can patient groups help?
They often call hypertension the silent killer that's hiding in plain sight, in that in many facilities worldwide, thousands of patients walk in the door every day, and a blood pressure is never measured unless the patient has symptoms. But obviously, hypertension is often asymptomatic. And so I think the role of patient organizations is vital in many aspects for raising community level of their awareness of the importance of hypertension and of screening, but also demand generation and advocacy for patient-centered care policies. For example, in many countries where we work, refills for chronic disease medications, the policies are for 7-day or 30-day refills, where patients have to travel far distances or lose wages to present to a primary care facility every 30 days to collect medications, and advocating for policies of extending to 90-day refill durations, of inclusion of medications in national insurance schemes and lowering out-of-pocket expenditures for patients. And the demand generation for setting the expectation of quality health services for hypertension, for cardiovascular disease care, and really strong primary health care is really a vital role.
Well, let's end there for now on strong primary healthcare, because that's a very important message, isn't it? Thank you very much indeed, Professor Gupta. I do have a question coming from JD Smith, but I'm going to bring that for our next discussion when Professor Wood will be talking too. So with no further ado, I want to introduce Professor David Wood, who's going to be our next speaker. He is Adjunct Professor of Preventive Cardiology at the National Institute for Preventive and Cardiovascular Health at the University of Ireland in Galway. And he's also Emeritus Professor in Cardiology at Imperial, and also a former president of the World Heart Federation. So very much welcome to you, Professor. You're going to talk about secondary prevention in the context of, I think, the COVID-19 pandemic. So thank you very much indeed to you, and the floor is yours.
Thank you. Thank you very much indeed for the introduction. And it is a real pleasure to join Global Heart Hub and this Unite Summit. And I want to offer you a perspective on prevention of cardiovascular disease, both secondary and primary, in the context of the COVID-19 pandemic, from which we are learning many lessons. Sorry, I'm just trying to move my slides on, but without success. Thank you very much for the technical support. All of us have been impacted by COVID-19. It had the most profound political and economic, social, and medical consequences for a world whose collective memory of the influenza pandemic, colloquially called the Spanish flu, from 1916 had almost completely disappeared. And for many who so tragically lost loved ones during the pandemic, or indeed were unable to be with their loved ones in the final days of their life, it had the most profound impact. If you look at the WHO dashboard, COVID dashboard, you'll see that this is from the 25th of November. There have been over 6 million deaths attributed to COVID-19. And I want you to remember that number when I come to the end of this presentation. And firstly, I want to look at the impact of COVID-19 on the presentation and management of acute coronary syndromes, of heart attacks. And one of the extraordinary findings is this trend, dramatic change in the general public's search for what to do about chest pain. And this was recorded by Google. And the countries shown here are the USA, Spain, the UK, and Italy. And this is a direct consequence of increasingly more difficult access to healthcare professionals, and therefore patients turned to the internet for advice on what to do if they had chest pain. And if you look at admissions to specialist cardiac centers, comparing 2019 with 2020, and in the blue are admissions during 2019, and in the orange 2020. And starting from the left, you'll see admissions for ST elevation myocardial infarction, the most life-threatening form of a heart attack, decreased during COVID-19, and the same for NSTEMI, non-ST elevation myocardial infarction, with no change for unstable angina. Patients were frightened to come to hospital to receive treatment for chest pain. And this impacted the care that they received. So here you see a comparison with management of STEMI in terms of time. So starting from the left, ST elevation myocardial infarction, symptom onset to admission, measured in minutes, was significantly longer during the COVID-19 period compared to the pre-COVID period. And door-to-balloon time was also significantly longer, and the same also applied to non-ST elevation myocardial infarction. Patients were presenting late, and as a consequence, they did not receive the timely life-saving treatments, the revascularization, stenting, open heart surgery, and so on, and therefore suffered more complications. And on the left, you'll see the incidence of cardiogenic shock, which for ST elevation myocardial infarction was almost 4 times or 3 times higher during the COVID period by comparison with the pre-COVID period, and a similar difference for non-ST elevation myocardial infarction. And on the right, you see the results for in-hospital mortality, significantly worse for both ST elevation MI and for non-ST elevation MI. So COVID-19 had the most profound impact on the delivery of acute care for patients presenting with a heart attack. But these patients had a double whammy, because as a consequence of COVID-19 and the need to divert cardiologists and specialist nurses to the front line, there was closure of many cardiac rehabilitation programs. And these data come from an international survey, which showed that almost half of all cardiac rehabilitation programs participating in this study had suspended their services. A third were seeing fewer patients. Just 1 in 10 were seeing as many patients as usual. So in the context of acute coronary syndromes, COVID-19 resulted in late presentations, more complications, and a higher case fatality, and therefore an even greater need for secondary prevention and rehabilitation, which actually was not available for many of these patients because these services were suspended or reduced. Now, let me turn to the impact of COVID-19 on the general population and the implications for primary prevention. And these data come from the UK Biobank study based on over 500,000 healthy adults aged between 40 and 69 years, in whom demographic, social, health risk factor data, and so on were recorded at baseline and then followed up longitudinally to document events, including all-cause mortality. And these investigators looked at, from the period of 31st of January 2020, looked at those who had died in this cohort, and their death was attributed to COVID-19, 459 such persons. And they compared their characteristics at baseline with 2,626 non-COVID-19 deaths over the same period. And what they found was that the following factors: increasing age, male sex, coming from an ethnic minority, especially Black African, being a current smoker, a former drinker, having cardiovascular disease, hypertension or diabetes, autoimmune disease or history of oral steroid use, and of course, importantly, being a healthcare worker, given the heavy exposure that healthcare workers suffered during the pandemic. All of these factors increase the risk of dying from COVID-19. And I want to particularly emphasize that prevalent cardiovascular disease and those with hypertension or diabetes were at particularly high risk. And this is quantified in this review. Patients with a diagnosis of cardiovascular disease were 4 times more likely to have severe COVID-19 infection and 6 times more likely to die. Patients with hypertension, 3 times more likely to have more severe disease, COVID-19 disease, and 2.9 times more likely to die. And the same was true for diabetes, 2.4 times more likely to have more severe COVID-19 infection and 2.5 times more likely to die. And in the European Society of Cardiology Task Force, which reported earlier this year on the impact of COVID-19 on cardiovascular disease, they concluded that whilst cardiovascular comorbidities are common in COVID-19 patients, the biggest impact of the pandemic was on late presentation, delayed revascularization, and as a consequent, higher case fatality. What they didn't comment on was the closure of secondary prevention programs, which will have further exacerbated the risk of these patients, leading to later higher cardiovascular mortality. Secondly, the presence of cardiovascular disease, prevalent cardiovascular disease, increases the risk of both severity of infection and the risk of death. And finally, the cardiovascular risk factors which we diagnose and treat in the context of primary prevention, such as hypertension and diabetes, are associated with a greater risk of more severe infection and an increased risk of death. And so COVID-19 has really exposed the vulnerability of unhealthy populations, and especially those with prevalent cardiovascular disease, hypertension, and diabetes. And I think COVID-19 has made the most powerful case for not just secondary prevention, nor just for primary prevention, but actually for primordial prevention at the level of populations. We need to build resilient populations. Now, at the start of this presentation, I mentioned the number of deaths attributed to COVID-19. In 2019, there were 17 million deaths attributed to cardiovascular disease. And the WHO issued a recent and very important report looking at global excess deaths associated with the COVID-19 pandemic. And during this period, 2020 to 2021, there were 5.4 million deaths attributed to COVID-19, but there were, in addition, 14.9 million excess deaths by comparison with the same time period in the 2 years preceding the arrival of COVID-19. And these excess deaths, some of these excess deaths will, of course, have been due to COVID-19 itself, but missed in terms of diagnosis because of a lack of testing and so on in many parts of the world. But many of these excess deaths will have been due to cardiovascular disease and the associated risk factors. So by comparison, 17 million deaths due to heart disease and stroke in 2019. 5.4 million deaths attributed to COVID-19, but 14.9 million excess deaths during the COVID-19 pandemic. And many of these excess deaths will have been due to cardiovascular disease, hypertension, diabetes, cancer, and respiratory disease, all of the major non-communicable diseases. And the conclusion from this is that we need to invest in primordial prevention because COVID-19 has illustrated the vulnerability of sick populations, and we need to build resilience in our populations to resist such pandemics in the future. Thank you very much.
Thanks very much, Professor Wood. Lots of food for thought in that. And as you say, COVID has shown just how important it is to get to grips with prevention of cardiovascular disease in all its forms. Let me just ask you, from what you just said at the end, about primordial, how we have to go back, not just to go back right to the very beginning. I just wanted you to expand, what do you mean exactly by that? When do we need to start this prevention and how do we do it?
So by primordial prevention, I mean prevention at the level of populations, not individual patients. And to address the major causes of cardiovascular disease at a population level, we need, of course, first of all, to address tobacco as one of the major causes of cardiovascular disease. And an enormous amount of work has been done by WHO and other agencies in tackling the tobacco industry. Beyond tobacco, we need to look at the food industry and the preparation and marketing of unhealthy foods, particularly ultra-fast processed foods generally. This is a much more complex area by comparison with tobacco. There is no argument over the epidemiological data about the risks of smoking, but diet is a more complex picture with aspects of diet which are actually very important for our health, our cardiovascular health, and many aspects of diet which are actually detrimental to our cardiovascular health. But I think the tobacco industry is the new tobacco for our generation and needs to be addressed. And then the built environment in which we live and work and play, dominated by the car industry, which impacts on the way in which we are able to be physically active or not, also needs to be addressed. So these are three different illustrations of areas where policies for primordial prevention at the level of populations are required.
Yeah, I mean, listening to your talk, it just seems like obviously it's very stark, but it makes somebody like me think, crikey, why aren't more people jumping up and down about it? Why? What needs to be done? I mean, obviously we're going to come on to the role for patient organisations in promoting, primary prevention, secondary prevention, but why hasn't policymakers acted more on this, would you say, and what can influence them?
Well, I don't think that the problem lies with WHO or with national governments and ministries of health with policymakers. I think the problem lies with the enormity of the challenges that big business plays in determining the way we lead our lives. In other words, the notion that we all have individual choice is a nonsense here. Actually, choice for populations is shaped by big business. And I think addressing the interests of big business is a huge challenge for governments. And so it's not a problem with policymakers. I think they recognize what we need to do here. I think the problem is bringing about change at a governmental level in the face of very powerful vested interests.
So what are the roles then for patient organisations in mitigating the kind of problems that you mentioned? Well, obviously COVID was, I like to say a one-off, but if you know what I mean, an extraordinary thing. But in terms of, big business, whatever, advocacy, what's the role for patient organisations to make people's health more resilient generally in a wider form?
Well, I think patient organisations have an enormously important role, in fact, a leading role, actually, because there is no better advocate for prevention than a patient who has or is suffering from the disease. But this needs to be addressed, I think, at different levels. I think there is advocacy for secondary prevention amongst patients who have already developed cardiovascular disease and who see the absence of services to address prevention and rehabilitation. In Europe, just under half of all patients with a diagnosis of coronary disease access any form of prevention and rehabilitation program. Why is that? It's because these programs are not as widely available as they should be, and they're not adequately staffed. And as a consequence, fewer patients than should be the case actually join these programs. And there is a significant delay measured in weeks or months before they can do so after discharge from hospital. At the level of primary prevention, where patients are diagnosed at high cardiovascular risk or with hypertension or dyslipidemia or diabetes, the same applies. These are patients with significant risk factors, and they can make a case for primary prevention, in other words, for management of their lifestyle and control of their risk factors, and optimizing the use of cardioprotective medications. And finally, of course, patients can be a powerful advocate for primordial prevention.
Yeah. Okay, thank you. I want to bring in Professor Gupta, who's into our discussion. We've got lots of questions to get through, actually. So let me come on to the slight minute. But Professor Gupta, any thoughts on secondary prevention and primordial prevention that that you've heard that Professor Wood talking about very quickly?
Many have called cardiovascular disease a pandemic that is far deadlier than COVID at its worst for all the data that Dr. Wood reviewed. But those cardiovascular deaths have become routine and are expected and somewhat ingrained. But COVID obviously has unearthed the weaknesses of our public health systems and our primary care health systems. And I think in addition to the primordial prevention and resilient populations, that hopefully this is the learning lessons that COVID has shown us are a catalyst for making the investments needed to strengthen public health and our primary healthcare systems as well.
Thanks, Professor Gupta. I just want to come on a slightly different topic. I think that you were involved in the World Heart Federation roadmap on secondary prevention. It's a few years old now. Have the ambitions of the roadmap been achieved?
I don't think they have, but actually the roadmaps was a very imaginative concept. And just to illustrate, guidelines are very common, at least in well-developed economies. We have guidelines on secondary prevention, on hypertension, on lipids, on diabetes, and so on. But producing a guideline based on best scientific evidence with no context in which to deliver that guideline makes it redundant. And the roadmaps, which were developed by the World Heart Federation, actually looked at the context in which evidence-based guidelines are delivered and the roadblocks that may prevent the successful implementation of those guidelines. So it looks much more holistically at health care systems and how they need to change from being disease-only focused to prevention-focused in order for physicians and allied health professionals to be able to deliver best quality care.
Okay. I've got several questions coming in. One, we've got some slides from question photo coming in to go up on display. We've got one from Stephen Macari. I hope I'm pronouncing that right, Stephen. He's president of AVEC. Patient organisations have an increasingly important place, he says, in European healthcare systems, but obviously globally, providing peer support and counselling. What's their role in influencing primary and secondary prevention? I mean, also you've mentioned, Professor Wood, that they're really important. So I'll come to Professor Gupta. What do you think in terms of providing counselling and peer support and anything else?
In addition to those critical areas, the building of community awareness and the primary prevention level of the factors of diet, of food, of hypertension screening are critical. And then the demand generation of expecting high quality care service delivery and advocacy around that.
Did you want to add anything, Professor Wood, to that? I know you've touched on it before.
Well, just a sentence, because I very much like the notion of patient organizations providing peer support and counseling. I think that is a very important role, but it doesn't address the fundamental issue in relation to secondary and primary prevention, which is the absence of health services and healthcare systems in those health services which actually address secondary and primary prevention. And in that context, I think patient organizations must become very powerful advocates. They must become political.
Okay. All right. Well, just one last question from Stephen. No, not Stephen, from Callum Ferguson. He asks, to that end then, Professor Wood, how can patients and clinicians work together to improve prevention and to, get across that political will you've just talked about? Is that one thing of working together with clinicians?
Well, there has been, I think, a sea change in the way in which patients now engage in the work that we health professionals undertake. And one example of that is in the development of evidence-based guidelines on which patient representatives sit, giving the patient perspective of their experience and how it could be improved. And so the development of guidelines is now always dependent upon engagement with patient organizations. And there are other examples of engagement of that kind as well, but we are now working side by side.
Okay, thank you for that. We were out of time, sadly. Professor Gupta, one last final wrap-up thought, what you take from this session as to what patient groups can do to help improve these things that we've been talking about?
I would say demand generation and the engagement in designing patient-centered services, that there's so much lip service played to the word patient-centered, but without patients as part of the table engaged in the process, services are so often not truly patient-centered.
Okay, that's brilliant. Thank you so much for your great contributions. I've got a question here from Lisa Pfeiffer of Heart Valve Voice Canada. I think it's quite a technical question, Lisa. I'll ask you to put that in the chat for Professor Wood, and he can answer it at his leisure. But thank you very much indeed for those questions. We're now going to have another video, animations and audio visuals, which you can download on the platform. Produced by the Global Heart Hub, but have a break for 10 minutes and come back after the break and we'll be talking about hot topics in cardiovascular disease. So thanks very much for your attention and thanks again to the speakers for their great presentations.